He served our nation 24 years in the United States Navy and he retired in 2014. And now he's spending some time with us. So thanks for your service, Brooks.
Thanks. Thank you very much. I had to make sure I got my my book of notes from Dr. Kunkel's lecture. That was awesome, so thank you. It's a tough group of patients to treat, so good tips, and I'm looking forward to trying some things. All right, so I was tasked with doing or tackling the esophagus abstracts, and it's all I did is I just did abstracts, so we can go through some of these, and these are all from DDW. There's my disclosures, and the first one that I wanted to talk about was dupilumab. It's also known as Dupixent, and probably many of you are familiar with this. This is a FDA-approved therapy for a number of different things, eczema and atopy and other type 2 inflammation conditions, but also in our world, EOE. And pivotal trials that were published, or pivotal trials, kind of published as one manuscript in the New England Journal of Medicine, are a really very good read. I encourage you to take a look at that. Evan Dillon is the first author there. And what that article describes is their phase 3 trials, and there was a part A that you can kind of see graphically up there. Hopefully it's big enough. And then a part B, and there's even a part C to these trials, different doses in these two different parts A and part B. The main difference between part A and part B is that dupilumab in that part of the study, really its own individual phase 3 trial, was 300 milligrams sub-Q once weekly compared to placebo. Part B included an every other week dose in addition to the weekly dose compared to placebo. And they had a whole host of outcomes that they looked at, primarily symptoms and dysphagia scores and such, but they also looked at endoscopic scores, and both visually with the EREFS score. Remember, that stands for edema, rings, furrows, exudates, strictures. That's an endoscopic score that our guidelines say that we ought to be using. I don't, but I should. But they also looked at inflammation, eosinophils per high power field, remission versus response, et cetera. This abstract from Inku Hirano, an expert in EOE, looked at, this is a post hoc analysis of this phase 3 trial. They took patients from both of these parts of the study, and what they were looking at was remodeling. And the reason I think this is important and why I picked this is that we tend to think about EOE primarily as being eosinophils. Maybe there's some motility abnormalities because of degranulation of the eosinophils and all of the things that EOs and mast cells release. But what we realized, and one of the stories that I think Dupixent's really helped bring out, and people like Evan and Inku, in terms of our knowledge about EOE, is that fibrosis and remodeling is also very, very important. That's what leads to the strictures, which leads to the food impactions, which leads to the complications and us coming in late at night. So this abstract looked at basically the remodeling in EOE. So in terms of the responses that they saw, so first I'm going to just touch on the EREF score. That they looked at inflammation scores, which is edema, rings, and exudates. Those are endoscopic measures of inflammation. And then the remodeling part of the EREF score is the rings and the strictures. That really speaks to fibrosis. And they saw improvement in both of those types of composite scores or subscores of EREFs, both in Part A and Part B, not statistically significant in Part A. But when you look at actually remodeling, I apologize for the size of that graph, but without even seeing the numbers, if you just look at the colors, so the purple colors are people who were randomized to Dupixent in Part A and Part B. Part A is up on top, Part B is down below, and the orange colors are the patients who are on placebo. So in this case, moving downward is improvement. And so this is looking at the fibrosis and the remodeling in these biopsies as patients moved through these studies, showing that improvement. And this is kind of an intuitive conclusion based on their primary results and the fact that the drug got FDA approval for this indication. But more data showing that dupilumab not only decreases eosinophils in many cases, or in a good number of cases, results in complete remission, meaning less than 6 EOs per high power field, but it also improves symptoms. We knew that. but it also targets the pathophysiology of EOE, that inflammation and that fibrosis. And so just more confirmatory evidence with regards to that, something that's actually, we think, treating the etiolopathology of EOE as opposed to just kind of putting a blanket over it. Another EOE study that I thought that was very interesting and something I think that's probably applicable to many of us, or really all of us, but probably more so depending on where you live and the patients that you see, is this concept of aeroallergens. That's another not really so emerging, it's emerged, but it's not just the foods that we eat that cause EOE, it's also aeroallergens and food pollen allergy or sensitivity, as well as other food sensitivities have really gotten a lot of interest and research over the last several years. And so what these individuals did is they looked at patients with positive skin prick tests. These are all EOE patients, or patients with atopy and GI symptoms, primarily EOE type symptoms. And then they put them on a 6-food elimination diet. And then, and this was the whole punchline of the abstract, they looked at their response to that 6-food elimination diet at different seasons, whether it was allergy season and pollen season or whether it wasn't. So among this is a small study, 58 patients, 62% had a positive skin prick test to grass and birch, so typical aeroallergens. And what they did basically is they put them on a 6-food elimination diet. They then gradually reintroduced certain classes of foods at 6-week intervals. Every time they introduced a food, they did an EGD with biopsies. They counted the EOs, et cetera. But I want you to look at the graph. So if you look at the full population, and then the patients with the skin prick test, full populations in blue, purple is the positive skin prick tests. Then you move towards, this is the efficacy of the 6-food elimination diet. So about a 60% response. That's pretty typical of what we see in clinical practice, somewhere between about 40 to 60%. Then if you look at that first box, kind of in the middle, that 77%, those are patients in their histology and their response when they were tested, when they were doing their 6-food elimination diet, who had a positive skin prick test during pollen season. A remarkably greater response than patients, I'm sorry, outside, I got it backwards. The big pink one is outside the pollen season, and then the dark purple is during the pollen season. So pollen makes a big difference, and that's really the point here. If you move out to the right, those are the patients who are negative for skin prick tests, and you can see that it doesn't really matter whether it's pollen season or not for them. There's probably a different etiology to their atopy and their EOE symptoms. So the reason that what the conclusions are here is that aeroallergens we need to be aware of maybe or are associated with EO reactivity and persistence in EOE. So when we have patients who are failing their 6-food elimination diets, or perhaps they've been stable and now they suddenly get worse, think about what's going on in the environment, what season it is. Perhaps there may be other things that we can use adjunctively, even for short periods of time, to mitigate that until we move out of that allergy season, or perhaps we need to move towards something more targeted towards type 2 inflammation, such as Dupixent. That's a bit of an extension of this, and that's not what this study was designed to show, but it's possible and likely that assessment for food pollen allergies may be helpful in predicting response and monitoring these patients. So moving away from EOE, I'm going to move towards reflux for a minute or so. This is an interesting study where they did these are patients who had ineffective esophageal motility, who also had hiatal hernias, and they were undergoing hiatal hernia repair. The median size was about 4.5 centimeters. So I generally think of that as a reasonably large hiatal hernia. Most of the ones I tend to see are sliding hiatal hernias between about 1 to 3 centimeters, but these are patients who are going through surgery, and they implanted this device called a reflux stop. This is implanted laparoscopically, and you can see what it's shaped like. And the whole point of this is it's meant to anchor the fundoplication in place and prevent the sphincter from moving into the thorax through invaginating the fundus wall and reinforcing that fundoplication cuff. So the point of this was to see how these patients did. And if you look at the time course here, pre-op, of course, all these patients, that's the GERD-Herkel score. On the left, all these patients were pretty uncomfortable and didn't feel good. And you look at their heartburn symptoms, regurgitation symptoms, same thing, all pre-op. After surgery, they felt significantly better with regards to their GERD-Herkel scores, and you can see the scores and how they changed over time from pre-op to post-op, and then they followed patients for up to 12 months and saw really very stable results. Again, another small study, but interesting in terms of this may be an adjunct. However, it didn't have a control group. So point of this and the conclusion that I would draw from this is that this may be a promising advance in terms of surgical approaches to patients with significant hiatal hernias who are undergoing anti-reflux surgery and correction of those hernias to perhaps prolong that response. We've only got 12 months of data here, and we also need a comparison group. So there's more study that needs to be done just versus surgery alone in a randomized fashion, or perhaps even with other adjunctive surgeries, such as a LINX procedure or something along those lines. All right, so this abstract I thought was also illustrative. We don't see a lot of abstracts about laryngopharyngeal reflux. Many of us, when we see various acronyms like POTS and EDS and other things, want to run away. I feel the same way about LPR. There's a lot of debate whether this really exists. I think it does, but I think we overcall it. I think our colleagues in other specialties significantly overcall this, but it probably does exist. This is a very interesting abstract where these investigators developed a special catheter, and they did various rates of infusion of low doses of acid in this catheter proximally. And what should happen in health when you expose the proximal esophagus to acid is that the UES should start to contract. So you see that out on the right. Those are healthy patients who had ultra slow acid infusion. And what you see when that acid is infused proximally, and that was the novel part of this catheter, is you start to see more contractile activity. However, if you look over on the left, and there were 12 patients in each of these groups, and these are 12 patients with LPR symptoms, typical LPR symptoms, you actually see a diminution in the UES pressure over time during the dwell time of that acid. There's no increase in UES contractility during the ultra-slow acid infusion. So the point of this is that there may actually be a physiologic basis to patients with LPR, and perhaps there's something that's going on with the UES that's contributing to their LPR symptoms. Now, how does this help us clinically? I don't think it does yet, but this is how we start to maybe get some therapies in the future to address this. And if we understand the condition, we may be able to actually treat it. All right, so talking about GERD still, vonoprazan versus lansoprazole. This is another, I thought, interesting abstract. Vonoprazan, if you're not aware of it, is the only approved PCAB thus far in the US. It's approved as a combination therapy with antibiotics for H. pylori therapy, but it is being considered by the FDA for erosive esophagitis. So these investigators did a meta-analysis of vonoprazan versus lansoprazole for erosive esophagitis, 4 randomized controlled trials, about 1,100 patients. The doses here of vonoprazan 20 milligrams a day versus lansoprazole 30 milligrams a day, about 25 to 30% spread with regards to LA grade A, B, and C. A small percentage of these patients had LAD esophagitis. And they looked at, and this is where I thought this was helpful, they looked at healing at various time frames. So this is healing at 2 weeks. We generally don't look until 8 weeks after we've initiated therapy if we're going to do a relook, and I do think we should for more severe erosive esophagitis to make sure there's no underlying malignancies, Barrett's, nodular Barrett's, or concerning changes. And there was statistically significant healing of vonoprazan compared to lansoprazole, 85% versus 77 at 2 weeks. At 4 weeks, it was not statistically significantly different. And then at 8 weeks, it actually was, again, statistically significantly different, but very small delta, 3% delta. Excellent healing with both therapies, greater than 90%. But what this showed was that vonoprazan was, in fact, superior to lansoprazole. Again, this is a meta-analysis, not a head-to-head randomized controlled trial. At 2 and 8 weeks, obviously, well, not obviously, but both medicines were very well tolerated, but the clinical significance of these differences is unknown. But we are going to start to see these PCABs come to us. There's other PCABs that are approved throughout the world, and we will start to see these in our clinical practice. What about testing for Barrett's esophagus? And this actually, I didn't plan this, but there's two posters. I think the only two posters I saw are on this exact topic, and I think one of them is this abstract. So I thought this was kind of a neat abstract. Current Barrett's guidelines do call for non-invasive cell collection techniques paired with biomarkers. Which ones we use, we don't really know, but as an alternative to endoscopy. Obviously, endoscopy is costly, invasive, subject to operator error if we don't get the, or even interpreter error on the part of pathology or variability. So these investigators looked at a novel device, and you can go see bigger pictures out in the posters. This is called EsoCheck. It's a 501(k) cleared cell collection device, and I'll show you a picture in just a second of what exactly this is. This is a real-world assessment in about 1,400, nearly 1,500 patients. Average sampled length of Barrett's was about 7.5 centimeters. They looked at gag reflex. They looked at DNA and cellular yield, as well as pragmatic effects of time required. So again, a relatively small picture up there, but this is a small balloon. You can see the size relative to a vitamin capsule or a gel cap. It's smaller than that. It's tethered to a string or a cord. Patient basically swallows that like they would swallow a pill. It's inflated. They move it up and down and collect some cells. It's got little ridges and ribs on it. And the average time that was required for this procedure was 2.6. There was a small group, about 9 patients. It was more than 10 minutes. I feel bad for those patients. I don't think I would like that. The tolerance was excellent, and that's shown in that donut graph there. And then if you look at yield, there was excellent yield with regards to DNA and cellularity. There's a variety of ranges, but the majority of patients had a significantly good yield with regards to DNA for biomarker analysis as well as cellular analysis. There were no device malfunctions. It was well tolerated. So this has the potential, I think, to improve frequency. Obviously, we need head-to-head data comparing to endoscopy and other techniques, but moving more towards this non-invasive monitoring or diagnosis of Barrett's and possibly dysplasia. So staying in that realm, this is a comparison of RFA versus cryo for Barrett's esophagus, looking at complete eradication of dysplasia, complete eradication of intestinal metaplasia, as well as safety. A lot more studies with radiofrequency ablation, 2,300 patients in these studies versus 6 studies with cryo. I was actually privileged when I was in the Navy at Bethesda to work with Mark Johnston, who developed one of the cryo devices. He actually had to turn the patent over to the Navy, interestingly enough. So we did some of the really early research in cryo, and it does work. 317 patients in these 6 studies. So a lot less data in the literature, at least. When you look at the overall ablation results, they were very similar, about 75% and 73% for eradication of dysplasia and intestinal metaplasia, respectively. In terms of complications, however, there were more complications with RFA in terms of stricture rates. And interestingly, and I don't know why, and I'm not sure this is true, it may be sampling error in terms of the number of patients, but there was an increased cardiac event rate that was noted in this meta-analysis with cryo of nearly 7%. Busy graph here, but the bottom line is these are very similar techniques in terms of their endpoints for eradication of dysplasia versus, as well as intestinal metaplasia, and I think they're complementary therapies, but we do need to get better appreciation with regards to the important differences, potentially important differences with regards to complication rates. Moving on towards something different with regards to the esophagus, this is an abstract came out of UNC looking at the timing of endoscopy for foreign body impaction in the esophagus. And again, I guess you can see that. It's hard for me to see on the confidence monitor, but what these investigators were looking at was complications versus non-complications, really relative to timing. You know, we get a call from the ER or from urgent care saying somebody's got a foreign body stuck in their esophagus and we need you to come in and do an endoscopy right now. Our guidelines have some variable recommendations with regards to when we come in. Does it need to be within 6 hours? Does it need to be within 12, 24? Et cetera. I was brought up in the era that, you know, you dropped everything and you rushed in and did it, and now we don't do that so much. And what they found basically is I've highlighted this in a couple of red boxes, and I omitted a couple of red boxes that I should have put in there, but there was a higher complication rate, and this is kind of intuitive, in older patients, sicker patients patients who underwent rigid endoscopy, which we don't do, and then patients with higher ASA scores, 3 at least. There was no difference, importantly, and that's shown in the green box with regards to complications or no complications relative to foreign body impaction in the esophagus to timing of the endoscopy. In fact, some patients went all the way out to 30 to 36 hours. I think I'd be hearing from my CEO of the hospital if I did that. However, within that 0 to 6, 6 to 12, 12 to 24, no difference with regards to complications attributable to foreign body impaction in the esophagus. This just highlights my take-home message from that. So urgent emergent endoscopy may not be as necessary as we once thought. Of course, it's all relative to what is ingested and what's stuck in the esophagus as well, and you have to use common sense. But interesting data there. And then I think this is my last one because I'm getting the Time's Up meeting, but I'm the next speaker, so I'll impinge on my own time. So this is another foreign body abstract looking at intubation and the cost impact of intubation. This is, if you're anything like me, you've probably had a gentle argument, maybe a stronger argument with your anesthesia colleagues with regards to the need to intubate a patient when you're doing an endoscopy for a foreign body impaction. And there's really minimal data to guide that. Of course, we want to get on well. We want patient safety paramount. This is a study that looked at patients who came in with foreign body impactions, whether it was food or some other bolus, and the timing of their intubation. So 382 patients were intubated. 2/3 were done early. That was defined as the day of admission, and then 1/3 were late. That implies that they were getting their endoscopy, probably at 24 to 36 hours. And then they looked at outcomes. They looked at mortality rate, length of stay, and hospital costs. And the hospital costs, the length of stay, and the mortality rates were significantly higher in patients who were getting late intubation and later procedures. Now, this may be conflicted by other comorbidities and events that were happening when the patients were admitted, and to explain why they were being delayed or why they were getting their procedures late and intubated late. So the whole story is not entirely clear, but I do think this speaks to we need to probably do these cases a little sooner rather than later. We don't probably need to come in and do it within 3 hours in most cases, but we do need to try to get these taken care of early to prevent those complications. This is the last one. I thought this was fascinating as well. This is a study looking at CBT for reflux. So CBT, or cognitive behavioral therapy, has been shown to improve insomnia. Insomnia has been linked to patients with reflux and their symptoms of reflux. And so what this was this a Rome Foundation pilot grant that sponsored a study of web-based cognitive behavioral therapy in patients with GERD who also said that they suffered from insomnia. So they used a sleep-based cognitive behavioral therapy model. So this was a CBT that was designed to help people with insomnia, not any other symptom, not irritable bowel syndrome, not stress and that sort of thing. They had weekly sessions, psychoeducation, cognitive behavioral techniques. Patients kept daily sleep diaries and a whole bunch of outcomes. The bottom line of what this shows was that GERD, and this is looking at GERD symptoms, as well as sleep over in the upper right, but GERD intensity, heartburn intensity, regurgitation intensity, frequency, GERD Herkel scores, all were improved with cognitive behavioral therapy. The medical therapy was kept constant. There were no changes to that. So I thought this was really fascinating. I think I am going to take this into practice for those patients who I do encounter, because I do ask patients about their sleep quality in my functional clinic. And I think this has some real applications possibly for helping our patients with their GI symptoms, but also their quality of life related to their disordered sleep. So those are a few of the esophageal abstracts that I thought were helpful and interesting at DDW. So, and I left one out. I'm sorry, I should have thought about this. So last one, I hope, and this is looking at one of those acronyms, Ehlers-Danlos syndrome and esophageal dysmotility. Very quickly, what these individuals did was they looked at high-resolution esophageal manometry in patients with Ehlers-Danlos syndrome and upper GI symptoms, so dyspepsia, thinking about impaired accommodation, but also esophageal motility disorders. And bottom line, they didn't find any. So these patients had just as many or just as few esophageal motility disorders. Out in the far left, it basically is a normal high-resolution manometry. This is compared to about 260 patients who didn't have symptoms who were undergoing high-resolution manometry without Ehlers-Danlos diagnosis. The blue are people who were co-diagnosed with POTS as well, and their results are the same. So there was no increase in the presence of esophageal motility disorders in this patient population. So when you get these patients, my take home from this is I don't need to send these patients to high-resolution manometry when they come in with their dysphagia symptoms. I may still do that, but I probably won't find much. So we need more data on that, but thought that was also interesting. So